Good afternoon, everyone, and welcome to the University of Manitoba Alumni and Friends Virtual Learning for Life program. My name is Tracy Bowman. I'm the Director of Alumni Relations and a very proud alumna. Before we begin, I'd like to acknowledge that the University of Manitoba campuses are located on the original lands of the Anishinaabe, Cree, Oji Cree, Dakota, and Dene peoples, and on the homeland of the Métis Nation. We respect the treaties that were made on these territories. We acknowledge the harms and mistakes of the past, and we dedicate ourselves to move forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration. Thank you, everyone, for joining us and making this event part of your day. If you're here in Manitoba, it's a lovely, balmy 32 degrees, so thank you for joining us for this hour. We're able to offer this program free of charge to all of our alumni and friends around the world, thanks to the very generous sponsorship of our affinity partner, IA Financial Group. Many thanks to them. You can learn a little bit more about the insurance options that they offer alumni all on our alumni website, so I encourage you to visit that. Before we get started, just a few housekeeping details. Today's session is being recorded, as you know, and we will post it on our website within about a day or so you're able to view it as many times as you'd like. You can also share it with friends, family, and fellow alumna. We encourage you to go to our site, as we have 30 plus sessions from over the past 16 months that you're, again, able to view many times. So please do go there. We have so much wonderful content showing the breadth and excellence of the research that comes out of the University of Manitoba amongst our graduates and amongst our researchers and professors. We'll also be using the platform Slido. So for any of you who've joined us for previous sessions, you're familiar with this website. It's slido.com, and the password today is VLFL23. And the reason we use that platform is that is how we are able to have you ask questions of our speaker at the end of the session. But I would encourage you to open that window in your browser right now. So if something comes to mind in the middle of the presentation, you're ready with the question and you can type that in. I'll be monitoring in the back end, and we'll try to get through as many questions as we can at the end of today's session. So now I'm delighted to introduce today's presenter, Dr. Esyllt Jones, who's also a two-time alumna of the University of Manitoba. She will be speaking on the topic of public health history and pandemic planning, the Royal Society of Canada COVID-19 Taskforce. Now, let me tell you a little bit about her. Dr. Jones is the Dean of Studies at St. John's College and is also a professor in the Department of History in the Faculty of Arts. Her research interests include the history of health and disease in Canada and the modern world, 20th century health activism and politics, transnational social movements, working class history, and the history of Winnipeg. She's an award-winning author of Influenza 1918, Death, Disease, and Struggle in Winnipeg. So with that, over to you, Dr. Jones.
Thank you. Thank you so much for that kind of invitation and introduction. I'm really excited about this presentation today because it's about a project I've been working on really for the last year, attempting to bring historical insight to discussions about policies, both within public health itself and with regard to preserving records of COVID-19. So my presentation today, just going to play here. Public Health History and Pandemic Planning discusses the Royal Society of Canada COVID-19 Task Force. Some of you may know the Royal Society of Canada is a body of leading scholars from the sciences, humanities, and creative work. People are elected, nominated, and elected to the Royal Society of Canada. And I'm a fellow of the College of the Royal Society and was invited to join the COVID-19 Task Force in, I think, May of 2020. So for the last year and some, I have been working with the Royal Society and a group of other people on the steering committee, meeting at first every week and now every 2 weeks to discuss a series of interactions and research papers, public outreach like op-ed pieces, roundtables, and so on. So the Royal Society's task force includes scholars from a really diverse range of research backgrounds, and you can see some of the papers and themes that have emerged on the slide here. So people who know about immigration and migrant worker rights and living conditions, policing and prisons, mental health, Indigenous health, anti-racism, vaccine hesitancy, homelessness, education, both in the primary, secondary, and post-secondary sectors, health economics and economic recovery, and history. I'm fortunate to be the only historian on the Task Force Steering Committee, as well as the only scholar from the University of Manitoba who sits on it. So it's been really an honor to serve the research community here and people who work in my discipline in the history of health and disease on this committee. So the steering committee members that oversee the working group, there's about 20 or 25 people, have engaged over 400 scholars in some of the papers that it has published. And you can see some of the papers that have come out on the RSC website, and I'll just click a link here. So that you can see some of the most recent publications relating to COVID-19 that the RSC has released. And those are free and available for anyone to download in English or French off the internet. So I want to talk about two projects that I was very heavily involved in. I chaired both of these projects. I was also involved in the Economic Recovery Working Group paper, but played a lesser role there. But these ones were specifically about historical preservation and the history of public health. So the first one I want to talk a little bit about is the paper that we released on preserving the COVID-19 archival record. And here I worked with other scholars, two University of Manitoba scholars, actually, Greg Back from my department, who's also the archival studies lead, and Shelley Sweeney, who some of you may know, who was the former head of the U of M Archives and Special Collections. And we worked with Joanne McCutcheon from the Association of Archivists, as well as Ian Milligan from University of Waterloo, on a report called Remembering is a Form of Honoring, Preserving the COVID-19 Archival Record. And again, you can see this and download it online if you're interested in reading some or part of it. So this project really does the work of history in the sense that it reviews for the audience and the reader some of what happened in the past in Canada's archival sector. And we're starting from a desire to influence policy to provide greater support for the preservation of COVID archives. One of the reasons that this issue really matters so much to me is because the flu pandemic, which is something that I've done quite a bit of research on, was for most of the 20th century largely forgotten in the historical record. And I don't want COVID-19 to become the 21st century forgotten pandemic. So as a researcher, the importance of archival preservation is always front and center for me. In the 40s to the 70s, Canada experienced what was referred to as the golden age of archival preservation. Expansion in collections at the Library and Archives Canada and the creation of new archival institutions across the country. By the late 1970s, there was a number of university archives and special collections like our own that were established. These university archives have now come to play a very significant role in the collection, particularly of private records, as well as the records of students and researchers at their own institutions. The end of the golden age of archival preservation really begins in the 1990s, where we have an overall contraction in government spending, fiscal retrenchment, which begins to undermine the public archives, but also the possibility of private records preservation, which is undertaken often by community-level institutions. So the pre-pandemic context is one of is in 2014, for example, from the Royal Society's expert panel report on archives, an era crisis acknowledged repeatedly by researchers concerned about vanishing and undervalued national cultural resources. So this slide sort of summarizes a few of the cuts that happened in this period, in and around this period. The Archival Community Digitization Program, which was an essential support for community archives that were seeking to digitize their records, which is an expensive business, as you can imagine, not just digitizing the records themselves, but also preserving the digital record appropriately. Funding for that was cut in 2009. The National Archival Development Program was discontinued in 2012. The Library and Archive Canada's overall budget hasn't been increased since deep cuts that occurred around that same time in 2012. So LAC is increasingly doing what it can do with quite restricted resources. And they have really focused on limited and targeted private collecting. So of course, they're legally required to do the preservation work of government records. That is in their legal mandate. But private collecting has tended to shrink quite a bit, with priority areas only being addressed. And at the moment, appropriately, one of those areas is supporting the preservation of Indigenous history in Canada. So archiving in a pandemic. What is going on in the pandemic in terms of preserving things as we go through this lived experience of COVID-19? There certainly is a lack of capacity and infrastructure that going into the pandemic, especially in digital archiving. So if we think, for example, of how we now sort of live, or a certain slice of society especially lives on things like social media, Facebook, and so on. Any digital archives that are created around COVID, it's an especially challenging circumstance to try to preserve those because the infrastructure wasn't there before the COVID pandemic started. Certainly, there are innovative efforts that are taking place in university archives and also a number of collaborative partnerships between different university archives, between community-based partnerships, and so on. The Steering Committee on Canada's Archives, which is a part of the Archivists National Organization, did a survey early in the pandemic in fall of 2020. And of those who responded, probably their data suggests that about 4% of archives in Canada are actually able to muster the resources to collect COVID-19 records. So these are really archives that were already stretched quite thin with limited capacity, then confronting a pandemic situation where, of course, they're having to maybe shift already restricted resources in order to be able to meet the demand for archiving in a pandemic. If you're interested in what's going on in the community, the first appendix of our brief includes a list of community engagement and partnerships in COVID preservation that you can look at. So if you're interested in it, you might have a glance. If you know of anyone who is doing the archiving of COVID records or organizations, especially if they aren't already on that list, I'd really welcome you emailing me and letting me know, because I'm building a new website that will provide an ongoing list of archival COVID-19 archival projects across Canada. So I really want to know what's happening out there. The recommendations of our report, and there are more detailed recommendations beneath these three key pillars, but they were, first of all, to strengthen available resources and infrastructure in the archival sector in order to preserve the historical record. And of course, this includes advocacy for increased levels of funding at all levels of government, from federal to local, for the very important work that archives and memory institutions in general are doing. We also argue for targeted capacity building measures for digital records preservation. And this is especially important in our view for the creation of community-led and community-controlled archival projects in marginalized communities, in those communities that have suffered greatly during the COVID pandemic, people who are not social elites, racialized people, Indigenous communities, working class people, migrant workers, and so on. So what we really wanted to see was some targeted measures at ensuring that those voices are preserved. Because unless we make a conscious effort to do so, it is unlikely to happen. The third one, the third pillar of the brief is something that academic scholars should be interested in, and that is to encourage the preservation of what has been a real flowering of academic research into COVID-19. And at the moment, the preservation of data and other sorts of records, such as oral interviews or survey results, are not always deposited in archives. So there's a default position toward record destruction, especially when it includes personal information. So we wrote a section in the report about how we might rethink ethical procedures in order to more likely support the deposit of archival research into university libraries in particular. Just going to check my time here. Okay, so this one is really my baby. The archival project, I really did a lot of facilitating of work by people who are experts in archives, which I am not. I'm somebody who has worked with archives and written the history of disease, but I'm not an archival expert. So the second project I want to talk about, beyond the COVID-19 crisis, building on lost opportunities in the history of public health, which is also available here on the RSC website, is a project that I spent quite a number of months working on with a group of other Canadian historians of health and disease. James Hanley, who is a historian at the University of Winnipeg, Heather McDougall from Waterloo, Laurence Monet from the Université de Montréal, and Catherine Carstairs at Guelph. And one of the things I'm really particularly proud of with this report is it does make recommendations about public health today. And so this is something I'm going to go back to discussing in a few minutes. It's also, though, critically showcasing all of the wonderful Canadian scholarship that exists in the history of disease. So even if you don't have any particular interest in the recommendations in the report, but you're interested in disease history, you'll find it interesting because it highlights so much rich research. And of course, we couldn't include everything, but we have a pretty extensive bibliography, and we've drawn on as much scholarship as we possibly could to try to trace the history of public health in Canada from sort of the mid to late 19th century until the post-SARS context. It's not a terribly short brief, I have to admit. It's over 30 pages long, but it tries to really condense and distill and synthesize what we do know, so that we can gain some insights from what is really a very interesting history. So I'm going to review some of what the report talks about, beginning with the 19th century. And, what I'm going to talk about over the next few minutes is really quite a condensation of what's in the report and a condensation of the literature as well, which is much richer than I'm able to present for us here. But for the sake of having somewhere to start in our paper in disease history, we focused on the emergence of semi-permanent and then permanent public health institutions in Canada from the age of infectious diseases, especially related to the emergence of infectious diseases like cholera or typhus in Canada. And the evolution that emerges from the 19th century, where we see two major insights that we can gain from that period about what it takes to be successful in mitigating the impact of infectious disease on the society. So these are basic principles that we can take from what happens in the very interesting period of the 19th century when you have the consolidation and the upheaval of industrial capitalism, the growth of global imperialism, as well, of course, as the impact of colonialism in Canada before, of course, the 1830s, but in our part of the world, intensifying around the time of Confederation as we negotiated the numbered treaties with First Nations in Western Canada, and as we experienced Métis resistance to Confederation itself. So it's a super fascinating period in Canadian history, which is full of upheaval and dislocation and change at the level of everyday life for so many people from so many different kinds of backgrounds, but which is also a really important period for the history of infectious disease. So cholera epidemics emerged in Europe and North America in the 1830s. And by the time we get to sort of the tail end of cholera, which is mostly brought under control by the 1890s, we have these principles of disease control. Basic principles like sanitation, the use of quarantine and isolation, but also things like health education and relationships with the public. And then slightly later, for some diseases, vaccination. So vaccines for many diseases were not yet available in this period. Probably the most famous vaccination and anti-vaccination movements that you may have heard of is around smallpox vaccination. So that those principles of disease control were learned the hard way through experience, through a lot of unnecessary deaths, and through the evolution of science and public health practices. The second factor, though, in this dual approach to getting disease under control was the importance of rising living standards and improved overall health, which occurs as wealth disparities begin to subside in the wealthy countries of the West. So over time, the impact of economic change does contribute to rising living standards, better housing, higher incomes, better nutrition, as well as opportunities for education, for example. So that dual approach is really important. And it's something that we should still be thinking about today. I want to qualify this by saying, of course, that there were significant social relations that meant that the benefits of this dual approach were not experienced equally by all members of society. Racism and colonialism, but also patriarchal social relations meant that health equity was always elusive and partial. And public health history, of course, reflects these social relations as well. And I just want to talk for a second here about the ideas about race and racialized Canadians and eugenic thinking that influence the new public health. So one of the things we wanted to do in this paper was to be sure to acknowledge from a critical perspective the limitations of past public health practice. And, you know, the historians have focused heavily on a number of these issues, such as immigration and border control and the impact of health inequities among Indigenous communities. So if I could summarize that literature, I might say that early 20th century public health in both English and French Canada was really shaped by ideas of eugenics, that is, the ideas of racial hierarchy and the importance of using science to influence human reproduction, as well as theories of scientific racism, which had been intensifying throughout the West in this period. In Canada, there was anxiety about, declining birth rates among white middle-class Canadians. And that anxiety was often framed by a discourse of race suicide. And when I put quotes around that, I do that because that was the term used, race suicide among white people. Racial degeneration was also a concern, and this desire for racial improvement. In other words, the limited reproduction of the wrong sorts of people and the enhanced reproduction of the right sorts of people, all of which tended to be framed by racial discourses. Newcomers, particularly those that weren't from white or culturally dominant backgrounds, were frequently blamed for their own health, ill health in that period. Despite the social factors, dislocation and migration themselves, hunger and poverty, as well as colonialism in the global sense as well. Of course, all of these things increase their vulnerabilities to disease. But there was a real emphasis on racialized and individual blaming of people for their health circumstances. When it comes to Indigenous history in that period, of course, we know that from the moment of first contact, there were epidemics that swept through Indigenous communities, and that continued well into the 20th century. And this was partly the result of exposure to new pathogens, but more significantly, as a result of the dislocation, trauma, and impoverishment that were the result of settler colonialism. So Indigenous people were, in Canada, regarded as a dying race. And, medical thinking and government thinking argue that they were particularly susceptible to infectious diseases like tuberculosis, but they were also considered a potential source of contagion for the white settler community. So public health has to acknowledge also the very significant element of racism, scientific racism, and public health racism that occurred in the period at the turn of the century. And this definitely influenced thinking about pandemic influenza. The flu pandemic is my area of expertise. And I'm happy to answer questions about the flu pandemic in particular later if you want to ask me some. Here I'm summarizing what of some of the legacies of health inequality were during the pandemic. So like COVID-19, the flu pandemic really exposes very difficult and festering social conditions. It challenged public health's ameliorative approach, by which I mean an approach that didn't really seek to resolve the underlying causes of ill health, but rather sought to address specific pieces of it where possible, such as housing, and also, the heavy emphasis on education versus actual treatment or care that characterized public health in that period. So the health problems that were caused, for example, by urban and rural and Indigenous poverty were not really, although these were acknowledged, the general view of public health in this period was that there wasn't much that could be done about it. Alongside public health is a lack of access to healthcare itself in this period, which I think had a significant impact on mortality rates from influenza. No Medicare. Access to healthcare was delivered mostly along a charitable model. Working class people, newcomers, had a difficult and tense relationship with hospital care. And, that was reflected, I think, in a failure of the system to gain their trust, which is something we speak a lot about with COVID-19, is the importance of that trust that can be built between healthcare providers and public health and the community. So there are differential death rates in Canada that are still, they're not as well researched as these death rates are in other countries that have better access to digitized databases than we do in Canada for that period. But there is evidence that in urban centers, death rates per population varied considerably by socioeconomic status and ethnicity, because this is 1918 to 1920 is the tail end of the proportionately largest immigration boom Canada has ever seen, right? Which ended at the start of World War I, where you saw millions of newcomers come into the country, where they often lived in ethnically segregated neighborhoods, had ethnically segregated access or lack of access to the labor force, for instance. So those inequalities were reflected in the propensity of people to die from influenza. The question of whether or not they were more likely to be infected is a much more difficult one. And from the nature of the evidence that we have is actually very hard to determine. Rural death rates, for example, in Saskatchewan, where my colleague Maureen Lux did research many years ago on rural death rates in Saskatchewan, were often significantly higher than urban rates. So there were a number of reasons for that, having to do with, the material conditions of farming, of rural isolation, of access to healthcare, so that many farm families had to confront the pandemic more or less on their own. And because influenza tended to spread through entire families, this resulted in high death rates. It was also cold, it was winter, people still had to go out and feed their livestock, for instance. So secondary infections like pneumonia, which were quite deadly in that era, were also a problem. And there was a significant mortality gap between Indigenous and non-Indigenous Canadians during the flu pandemic. And this is true across Canada. In Western Canada, in provinces like Alberta and Manitoba, death rates were 10 times higher among on-reserve Indigenous people than they were in the non-Indigenous population. So we have a lot to think about when it comes to the experience of pandemic influenza in Indigenous communities. So post-pandemic, after the flu pandemic is over, the lessons that should have been learned about the impacts of these inequality really didn't filter down into health policies, into public health itself, or into social and economic policies. So there was a period in Manitoba, for example, during the war when there were new legislative social programs introduced. The Mother's Allowance was one of the most significant of those, which gave a small, rather punitive pension to women whose husbands had died, who had dependents. But the closure of World War I and the movement into the 1920s really shuts down many conversations about the need for welfare state supports in Canada. And this is, of course, only intensified by the Great Depression. So when we think about the period of the 1920s and the 30s, there are some improvements to the social safety net, and there are some improvements to healthcare and to public health. Many of those are retrenched during the Great Depression. But we don't see an emergence of a national model for income support, for example, nor do we see national or provincial schemes for healthcare. So one of the things I want to talk about for a few minutes is the relationship between the emergence of Medicare and the 20th century evolution of public health. So there are a couple of things going on here that are really important to consider as we move into the post-World War II years. One of them is that over the course of the 20th century, the number of deaths, proportionately speaking, to infectious disease falls gradually. You see rising living standards contributing to that, as well as vaccinations that become available in the 1950s and 60s for an increasing number of so-called childhood diseases, or diseases that were mostly experienced by children. Polio was the most famous of those in the mid-1950s. Measles, mumps, and rubella were all developed in the 1960s and then combined into the MMR vaccine in the 1970s, early 1970s. So increasingly, public health is shaped by the overall decline of infectious disease, which seems to make infectious disease less of a priority or a concern, and a kind of enthusiasm for what I call the quick fixes, or the technological fixes. And this is also something that my colleague Laurence Monet has written a lot about in her work. So whereas public health had been advocating a lot of non-pharmaceutical interventions, as we call them now, and significant public health educational models, these tended to be overtaken by the delivery of things like vaccines. So there's that going on the one hand. On the other hand, in the 1940s especially, you see the emergence of quite powerful social movements for the introduction of public health insurance or socialized medicine. This takes some time, of course, more than 20 years before we see the final establishment of a national Medicare program in the late 60s. But the introduction of health insurance as the main political priority in healthcare in this period shifts the balance between public health and medical care, or between prevention and cure. As soon as Medicare is introduced, or even before Medicare is introduced, but certainly as soon as provinces start to deliver insured medical services, including insured physician care, money becomes an issue, right? The funding demands of Medicare also push public health to the side and turn it into what Mark Lalonde famously called it, a poor second cousin in the healthcare system. It's also important for us to realize the ways in which Medicare and public health continue to be framed by racism and colonialism. So Medicare in its early period mostly excluded Indigenous people. So for example, in Saskatchewan, when the first socialized system of health hospital coverage was introduced in 1946, most Indigenous people were not eligible for it. There was still a sense that healthcare as a treaty right, which was advocated by Indigenous people, had to be resolved at the federal level. So there was this struggle over the treaty rights of healthcare, while provinces introduced some programs which they then sort of said, well, this is not about Indigenous people. And I think it is very important, and I've been working on this history with a number of scholars for several years now on the exclusions and the absences in Medicare. Medicare was not fully universal. Indigenous healthcare in that period, as Maureen Lux has argued, was racially segregated, provided in Indian hospitals or in Indian wings of hospital institutions. So all of these things contribute to a continuation of deep disparities in health outcomes in the period after the development of Medicare. So the end of infectious disease. What is going on with infectious disease in this period? Because it's a really interesting time between the conclusion of World War II and the reemergence or sort of reemergence of infectious diseases such as HIV and SARS in the 1980s. So when I teach a course in global infectious disease, I have lots of quotes from this period about how leading figures in public health really believed that we could vanquish infectious disease. And of course, smallpox was eradicated. But other attempts to eradicate other diseases were much less successful for a lot of very complicated reasons. So we have a kind of a window period here, if we might like, between about the mid to late 1940s and the 1980s, relatively short window period, when infectious diseases are seen to be largely, certainly serious epidemic outbreaks, a thing of the past. But by the 1980s, of course, there is obvious renewed risk and diseases emerging, most of which had no cure or vaccines available for them. This coincides as well with that period of neoliberal retrenchment in public spending. And public health here suffers from its low profile and the way in which it has been relatively pushed to the side within our healthcare system. It's actually surprisingly difficult, because I tried to do this at the behest of Tom Mary, actually the chair of the Royal Society's Taskforce on COVID-19, to figure out exactly what was going on with funding even at the federal level, but maybe more significantly at the provincial level for public health in that period. Someday maybe I will do this, but it was basically impossible for me to find this information in other published sources. So I would have to build it from the ground up myself, which I think is probably totally worth doing, but I haven't yet done it. So it's hard to tell exactly how much funding was reduced, especially in real dollar terms, between the introduction of Medicare and the turn of the millennium, for instance. I did look at last year's spending on public health in the Manitoba provincial budget before COVID-19. As far as I could tell, we spent less than 1% of our own overall annual health budget on public health, which is I think, a rather shocking number. I mean, I found it shocking. There might be some spending in there by regional health authorities that wasn't included, but I couldn't find it. So it's really important to consider what a teeny weeny slice public health now gets. When the idea of the end of infectious disease seems like a quaint sort of aspect of our past thinking, right? This balance or imbalance between prevention and treatment has really been revealed to us during COVID-19. So the recommendations of our report, and this was something that I really enjoyed working on. Whether it'll have any impact on policy debates, it's hard to know. Certainly the Public Health Agency of Canada has showed quite a bit of interest in our report, actually, so that's hopeful to me. The first thing we recommended was an investment in prevention through that dual approach, right? The dual approach of disease control, healthy disease control mechanisms that are properly maintained in between pandemic or epidemic outbreaks, but also attention to the need to minimize health inequity and social inequity more generally. And we wanted to increase accountability around social determinants, which is, now a very frequently used term and has been for decades to describe the impact of social inequality on health outcomes. We wanted to introduce accountability mechanisms. So one idea that we had in the brief was to introduce a parliamentary or a legislative reporting mechanism, a kind of sort of like the parliamentary budgetary officer, but for public health, to ensure that we're at least moving the line in the right direction in the relationship between overall social inequality and health inequality. So what are we doing? What are we spending? And is it working? And are we going the right way? We also really thought that engaging the public is very important for addressing both of these issues, gaps in public health funding and for inequality. So we're calling on the federal government to invest and financially support health advocacy groups at the community level. And finally, to create an equitable public health culture through a return to more of those non-pharmaceutical interventions, especially education, to create a genuine public health culture. And I think at the end of the day, Canadians have done very well on vaccine hesitancy, especially relative to some other parts of the world, right? But we still have to continue to build the relationship of trust between public health and the people who need it. And that's about accessibility and providing meaningful services for people. And it's also about building this sense of shared responsibility. And Dr. Monet talks a lot about this in her work as well, about building a sense that infectious disease outbreaks are not so much an individual problem as they are a shared problem, and that we need common solutions together. And vaccination, of course, is a perfect illustration of how this works, but there are many other examples. So working on creating this equitable public health culture through education. That's about it. And I wanted to thank you and also to give a little plug for a new project I'm working on, which is called Pandemic Histories. It has a few pieces. This is funded by the Research Professorship in the Humanities that I take up on July 1st. A WordPress site, which isn't quite ready yet, but I'm hoping will be ready in the next couple of weeks, pandemichistoriesca.wordpress.com, and as well as a Twitter feed at panhist. If you're interested in subscribing to the WordPress site, you can always email me and I can add you to an email sort of advertising list that I'm building. So if you're interested, just give me a shout. Thank you very much.
Thank you so much, Dr. Jones. That was really interesting. And thank you for going through the history of everything, and then also what you as your team within the Royal Society of Canada has come up with. So as we're encourage everybody to just post some questions on that Slido site. So as we're waiting for some questions to come through, you were saying, I just wanted to, there's one point at the end there I was thinking about when you were saying, I was writing down the equitable public health culture and about some of the things that we can do. And you were saying that vaccines is obviously, one way as part of a society is that we can, in terms of helping each other. You said that there are some other ways. Do you think you could go into a little bit of detail as what some of those other ways might be in terms of the equitable public health culture?
I think one of the ways we build that is to create a health system that is a little bit more oriented toward preventive care and treatment, especially primary care, being brought together. So, when we have babies, we have a relationship with our nurses or our pediatricians to get them their jabs when they're babies. But then that relationship sort of fades away once your kids are through their kind of childhood immunization period. And I think there's lots of ways that public health is doing interesting stuff all the time that is not well integrated into the primary care system. And one of the ways of building that shared culture, I think, is to have the two come closer together so that we're kind of living it all the time. When we're accessing healthcare, we're also accessing public health education. And I think this has been an aspiration for many years in public health. I don't think it's a new idea.
Okay, thank you. That makes a lot of good sense in terms of how we can integrate it. And I would say I would agree with that in terms of the public versus of when I had my two babies, which was some time ago, and that disconnect now, I don't have that relationship. So I appreciate that. That's very interesting. You said that you would be willing to take some questions about I guess the Spanish flu, about the pandemic in 1918. Is there, I don't have a specific question, but is there anything in particular you wanted to share in terms of comparabilities, similarities or dissimilarities? We were talking before, just for our viewers, you and I were talking earlier about that you've been in the media quite a bit because of your expertise in this area and where there have been similarities and not. I'm just wondering if there's anything that you could share with our viewers today on that subject.
Sure. And I mean, you see a lot of resonances when it comes to the impact of disease on communities that are, not as wealthy or racialized. So right from the beginning of the COVID-19 pandemic, I was really thinking about and looking for the emergence of those social inequalities, and also for the emergence of resistance to resistance in general, right? And so the emergence of Black Lives Matter in the early pandemic, I as a historian, I found really fascinating because we often see these attempts to sort of take this moment when we're all in this shared social experience and to mobilize politically around inequity. So the work that I've done on influenza is partly about the relationship between inequality in Winnipeg and the emergence of, or the support of labor rights movements, particularly the connection between the pandemic and the general strike, which is not a straight line, right? But you can, now that people have lived through a pandemic, they kind of understand how it works, right? About how there is just a way that we are experiencing this inequality, which is often quite buried. It's right there at the surface. It's just there for everyone to see. But it doesn't just end there. It also has to do with people feeling in some way energized by that moment. And I think it has to do with social solidarity and the importance of that solidarity to how we survive pandemic events. So public health and government are important, but so are our communities, our families, our neighbors. And all of these things mean that there could be the emergence of resistance movements. And I hope someday people want to pick that apart too, the relationship between Black lives and COVID.
That's And I had seen the direct correlation until you've just mentioned that. And as you're saying, comparing to the general strike in 1919, does it take a pandemic for us to see in society that there are, inequalities, whether labor movement, members of racialized communities or whatnot. So that's very interesting. As you're saying, and would Black Lives Matter have happened, during a non-COVID time of year? I mean, there was an incident that happened in the United States, but would it be the same situation? So yeah, that's very interesting. We have a question that's just come through. Let me just put it here. So Chris, if you're able to put it on screen for us. Someone just thanked you for your talk. But the second one, as the vaccine rollout starts to fade out the pandemic, are you worried that the interest of investing in public health will fade out too?
Well, that would be the pattern, and it makes a certain amount of sense, doesn't it? I mean, we can't live in this moment really forever. We're all, at one level, we're all really wanting to move on. But on the other hand, we want to be able to become more resilient as a society, and to find deeper, more meaningful ways to prevent the scale of an outbreak like this one. So yes, I'm worried about it. I think public health also always faces this conundrum. Certain things, fear is a big motivator, right? And that's only natural. So that's why it's important that governments actually not just prevaricate, right? Don't put it off for, some other later date. The time to act on some of these things is now, while people are living every day with what we've been through. And for some people, of course, their memories of this are not going to fade anytime soon either. And it's important that those people's experiences also be honored, and that their voices be listened to. People who lost elders, for example. I was reading some stuff about the Quebec inquiry today. It's just, it brings back just all of the terrible feelings that we had about the loss of elders in the early part of the pandemic before they were vaccinated. So it's an excellent question. I think that's one of the reasons that I feel so strongly that the public advocacy needs to be what underpins change. And because that's the one thing that keeps the issue in the public's eye is, ordinary people advocating for what they need. So, that deserves recognition and support from governments.
I can't help but think, it makes me think of those, the old adage, history repeating itself, and you as a historian would know about if and when history repeats itself. If we think about, the 100 years ago and now where we are, and the repeat of, where we are with public health and advocacy, as you're saying, the advocacy movement and whatnot. So, and us wanting to get back to normal life as much as we're able to. I mean, is that really a reality, getting back to normal life, seeing what you've seen over time in terms of when you have these huge upheavals in history? How long does it take for us to return to normal life?
Yeah, that's a hard question. It partly depends who you're talking about. One of the major differences between the flu pandemic and COVID, at least as we've experienced it in Canada, I think it is going to end up looking differently in places like India, for instance, was what we call the W curve of mortality for flu. So a lot of people dying in between the ages of 20 and 40. So you had a lot of familial impacts because those people were, often mothers and fathers. So that, combined with the loss of World War I, created very significant familial impacts. And what was normal for those people going forward, their lives were forever changed, right? I mean, kids who survived that, some of them were raised in orphanages, some of them went to live in extended family, some of them were parented in single parent households. And if those were female led, single parent households, they probably experienced a lot of poverty. So there's not a lot of moving on from that, I don't think. And one of the frustrating things about the flu pandemic is, people had no way to really talk about that, because the society was so very, very invested in normalizing. Historians have written a lot about the attempt to normalize after World War I and World War II too. And to normalize after the pandemic, such that memories of the pandemic really get sort of suppressed. So they're still there under the surface, but there's not a public recognition of them. And in my opinion, this doesn't really help, right? It makes it harder for people to rebuild their lives, because for young children, for instance, they never really quite understood what it was that happened, some of them. Right. And I've talked to those people late in their lives, or people who were children of children, flu children. So normalizing is a really difficult question. And I think the panel I was on last week at University of Calgary, Mayor Nenshi said, "I don't want to go back to normal. Normal wasn't good enough." And I would really echo that. Normal wasn't really good enough. We have to do better in many regards when it comes to health equality.
And in a number of other areas of our life too. We hope that we've learned from what is a need and what is not a need, right? And what is really important to us as people. So that's interesting. And then also seeing, we were also talking beforehand, you were saying that you've been getting a lot of questions about, are we going to have a roaring 20s after this pandemic, like we was seen with the Spanish flu? And so, the impacts from an economic standpoint, personally, as well as, a global economy and countries, and how some will do better than others. I don't know if you wanted to add on that from an economic standpoint as to, again, looking at over history, what we've seen in terms of, I'm assuming, some countries or some people doing better than others.
Well, I think there always are some permanent shifts, culturally and economically, post-infectious disease outbreaks. But we don't necessarily know what they're going to be. Whether COVID-19 has a significant impact on shifting any global inequalities, it's hard to say, because those inequalities are already so very deep, and they're shaping people's COVID experiences in significant ways. But the specific things that become different about our lives, I think I kind of think of it as putting looking into the crystal ball, which is impossible for a historian. There will be responses, but I just can't really say what they are. I mean, I would say that the 1920s in Canada was overall not characterized by significant economic advancement when it comes to the number of people, the living standards of ordinary people. There were some changes toward the end of the 1920s, but the early 1920s were not really great. And then, of course, you had the economic depression, which, probably was after the flu pandemic, it's the depression that generates so much social change. And in many cases, of course, this is the same generation of people that you're talking about. So their pressures during the depression are born, their advocacy is born out of many of the same things that their advocacy is born out of in the early 20s or in the late teens, which is this sense of there being a shared experience. So, the Great Depression brought many people into poverty who had never lived in poverty before, and it changed the discourse around whether you were personally responsible for your own poverty, or whether it was a structural problem. And maybe we're in for that kind of long-term conversation in Canada about wealth inequality, which I think would be a really important conversation to have, because inequality has been growing in the West. And do we want that, or do we want to try to reverse it?
Right. That's so very interesting, and I appreciate you mentioning that. I don't think we have any more questions, so I'll put one more request out for people. But I'll give you, Dr. Jones, the one of the last words. So besides your blog, which we're all going to sign up for, and we're going to learn more Is there any other last thoughts you wanted to share with us in terms of other resources we should be looking at to learn more, or any other last things that we should be seeking out just to become more aware of a number of the issues that you've mentioned?
One of my favorite things for the last several months has been a video recording on YouTube that's available of a guest lecture that Brenda Child gave at University of Manitoba in March. Brenda Child is a Minnesotan Ojibwe historian, and she gave a lecture on the history of the jingle dress, which is really, really moving. So if you just Google Brenda Child, St. John's College, you'll be able to find it. I don't have the link, I don't think I can get the link fast enough for you, but it's a wonderful, wonderful lecture. And she's an incredible scholar, very, very engaged, very humane. So watch that.
Okay. Great advice. We will do that. And if you do find the link, if you want to send that to us, we can also send it to all of our viewers if they wanted to look at it at another time.
Sure. Yeah, I can do that.
Wonderful. Okay, so I think we're going to end it there. So thank you so much for that really, really interesting presentation. Learned so very much about how history touches a number of different areas and where we're at with COVID-19 and the wonderful work that the Taskforce is doing. So thank you very much for sharing that with us. To all of our viewers, we'll be sharing a link with you today about today's session, as well as a survey, as we do usually. Please provide us with your feedback. It's the only way that we're able to improve. You can share other topics, speakers, everything really. We're interested in everything that you have to say. The last thing I'm going to mention is just if Chris is able to put the last slide up on the screen, I just wanted to put a little bit of a plug. So speaking of surveys, I just wanted to put a little plug in. Right now, the University of Manitoba is undergoing a process called Our Shared Future, building on our strategic plan. And in the effort of getting your input. And right now, we have a process going on at the university open to students, staff, faculty, and alumni to participate. You may have already received an email from President Benarosh. We will certainly send you a link to it, no matter what, if you're on that email or not. And as you know, we've been talking about the unusual circumstances that all of us have been facing over the last 16 months, and how that affects a usual extensive strategic planning consultation process that would normally happen, especially when you have a new president arriving at the university. So right now, the university will be continuing with its current strategic plan, but is asking for feedback. So it's able to identify some shorter term direction and priorities over the next 18 months, as you can imagine how the impact of COVID-19, of how that impacts our students, our staff, our faculty, and how we educate the students and leaders of tomorrow. So we do want to hear from you, so we'll send that link to you. And so this is our last session before we break for the summer, and we will be returning we'll be returning in the fall, and stay tuned for what our sessions will look like in the fall. We'll make sure to give you that information. So thank you for joining us today. Thank you for participating along the way. I wish you and your family a wonderful, safe, and very healthy summer. Thank you very much.